I witnessed, recorded, and produced these videotapes of the Washington, D.C. hearing. Their authenticity is above question.
This is produced as part of the ongoing work on the website, thewaythetruthandthelife.net.
This is a hearing about the government licensing the electrocution of people to cause grand mal seizures. Think of the millions of dollars, taxpayers' money, spent to pay psychiatrists and their supporters and for the worldwide travel in putting this conference together, while the victims and opponents had to pay their own way.
The first question, what is the evidence that ECT is effective for patients with specific mental disorders? The procedure now is for us to discuss the first question, which is the question of the statement on efficacy. If you raise your hand, I will call on you. As Dr. Jacoby indicated, one of our major goals this morning is to have some feedback as agreements or disagreements from the individuals who provide us with expert testimony during the course of the sessions yesterday and the day before, as well as hear from individuals who disagree with our conclusions. Would you raise your hand and then I can point to you? Yes, sir.
On first hearing, it seems to me that there's only one point in this statement that I, as a physician, would suggest a modification on, and that is in the statement concerning the recommendation that an anesthesiologist administer the...
Excuse me, I'm sorry, let me try to make it clear. We're going through question by question. The first question is what conditions for which there's efficacy. And we'll come to that in the fourth question. And I want to try to do that because different members of the panel have a responsibility to be ascribed to that. So if I could ask you to try to focus to the first part of our discussion on our answers to the first question. Would you raise your hand? Second.
Just a minor point, but I think there's an inaccuracy on page 5, which states that there has not been any study using current DSM-3 nomenclature on endogenous and unendogenous. But two studies that were published in the last year or so addressing that question. I know one was published by almost kind of interesting, but I was surprised. They found no difference in efficacy when patients were diagnosed according to endogenous and unendogenous.
I think the panel could all hear you. Why don't you come to the microphone and make sure that so the audience can hear your comments too. I think it's very important. You can use the one up here, it's closer for you. Thank you.
I think it's a relatively minor point in the efficacy section, but I think there's an accuracy on page 5. To the extent that the statement is that there have not been direct studies using current DSM-3 nomenclature on the question of whether patients who are diagnosed as non-endogenous or non-melancholic different therapeutic response from those diagnosed the other way. There have been 2 such studies that have recently published.
And they show what?
And surprisingly, at least to me, they showed that there was no difference.
So ECT was not more efficacious in their use?
That both groups were responsive, endogenous and non-endogenous, using the DSM-3 nomenclature. Coriol and Iowa was the source of one of these tests.
The panel is, please feel free to ask clarifying questions.
Was there a placebo control or sham or something?
No, this was this work was within a patient cohort establishing whether different diagnostic distinctions were critical to accounting for individual differences in therapeutic response.
They all have major depressive disorder?
Yes, they were all diagnosed as mood
And were they, what was the rate?
I'm sorry, I can't comment.
But it was appropriately high?
Yes. Yeah, these were patients who generally were responsive.
Were these studies presented during the last 2 days?
They were not mentioned as far as I know. They were not presented. No. Just wanted to give that the literature indicates a contradiction with the statement.
Could you provide us with the references of the names?
I can try.
Are there any other comments? Yes, Dr. Bregan.
In regard to what Dr. Sackman said, what you're saying in your report is more consistent with conventional wisdom in psychiatry, and I think that 1 or 2 studies out of several thousand should change the conventional wisdom, even though I would rather not even see the conventional wisdom that's so highly promoted. I think there's a basic consistency between using terms like most convincingly to describe the effect of the treatment when in the earlier paragraph you have so clearly noted that the effect doesn't last beyond 4 weeks, as far as we know. I think that your analytic description is more accurate than your concluding evaluation. I would like to see inserted that those 4 weeks are the weeks of delirium. That is, if the only studies that show any effect in ECT, this is critical, the only studies that show any effect in ECT show an effect during the period of delirium. And if you were measuring any higher emotional response, not just depression, but the ability to love, the ability to have a religious experience, the ability to work, the ability to take care of your children adequately during that 4-week period, they would all be reduced, not just depression, so that there is a misemphasis here in the statement. In fact, during those 4 weeks, the patients were often incompetent.
They don't want to respond to that again.
Well, we have said in our report that there have not been any studies which have used outcome measures of quality of life and social functioning, and we urge that those are the types of studies that should be done. We've emphasized that it's the outcome during the 4 weeks is reduction of symptoms, which seems to be documented in those studies. The reason that there's no data beyond 4 weeks is that studies are only done for 4 weeks, and after 4 weeks, the patients in both treatment groups have gotten other treatments, and therefore it's not possible to evaluate.
Dr. Brandon.
Thank you, Mr. Chairman. May I trespass slightly from my brief and congratulate the panel on the production of a remarkable document. Although I don't entirely agree with the emphasis in every respect, I think you have done a remarkable job in producing a clear and authoritative document. As far as the point which Dr. Breckenridge has raised, I can assure him that none of our patients had persistent delirium during that 4-week period. Many had a transient delirium after treatment, but the majority showed a dramatic reduction not only in symptoms, but a marked improvement in quality of life and the total absence of delirium through that 4-week period.
Judy Chamberlain. Next to the microphone, find Dr. Brandon.
Yeah, on page 3, in the first paragraph, you're talking about the available controlled clinical trials to not extend beyond treatment acute episodes, i.e. about 4 weeks. Then just below that, in the paragraph, the efficacy of ECT has been established most convincingly in the treatment of severe delusional and endogenous depression. There's just a real contradiction there. For a study that has insisted on clinical controlled evidence in order to make any statement, it seems to me you must put in that in that statement, at the very least, the efficacy of ECT has been established for 4 weeks, and not instead of most convincingly. There's just a real contradiction.
Yes, sir.
Yes, some of the indications that you covered in some of the efficacy studies, certainly I congratulate you for limiting them to controlled data and noting when there's no controlled data. A couple of things that were left out that I would like to see included, just so that those of us that do use the treatment sometimes, these indications are some of the organic depression, such as that associated with Parkinson's disease, where the Parkinson's disease itself gets better with ECT in many of the cases, not all. And the other is in the case of chronic pain syndromes associated with depression. Even though these depressions may not be considered endogenous, I think there's anecdotal data, which of course in this group I would not propose as being controlled data. I'd like to see that at least mentioned so that it wouldn't be taken as a total exclusion to use ECT in refractory cases of this type.
Does anyone want to respond to that?
Are there any controlled clinical trials that you could provide us references for?
As far as I know, there are no controlled clinical trials. There are only at most a 2 to 3 patient series where there was, again, these patients obviously were reported because they had a positive response. I would say that that's an area that needs further research. What I'm saying is I would hope that the use of ECT in those 2 situations I mentioned would not be proscriptive. But no, they're just anecdotal reports that I know of.
Alan?
I think that the logic that we employed was that the indications or recommendations have to be coming from controlled trials. The issue about case reports or anecdotal reports, we're not saying that they're inaccurate, but to offer general efficacy to the treatment for those is beyond the usual and customary and reasonable scientific inference. The fact is that we did recommend that controlled trials be done in other groups to clarify it, for which benefit can be obtained. We cannot recommend treatment at this time. Dr. Prime.
Yeah, I'd like to follow up on the point by Hal and the previous gentleman, in that some depressions that do not meet the criteria for endogenous depression can be every bit as severe as endogenous depressions, including risk of suicide and severe incapacitation. Now, it's possible that ECT may prove to be effective in severe non-endogenous depressions that fail to respond to an adequate trial of antidepressants. In the statement, this possibility should not be excluded, and should the suggestion be made that ECT would not be effective for them. And what I would suggest, perhaps, is that on page 5, in the last sentence of the first paragraph, you might say that patients with major depression that is non-endogenous, non-melancholic have not yet been directly studied using current DSM-3 nomenclature. And instead of the last phrase, I would suggest you say that effectiveness of ECT in severe endogenous melancholic depressions that fail to respond to an adequate trial of antidepressants requires further investigation, rather than equating most of the major non-endogenous depressions with other less severe forms and indicating rather positively that ECT would not be effective for them. I think you close off a very valuable potential use of ECT with this statement.
We had a series of, I think it's important to respond because I think your comments are well taken. The issue that the group dealt with was in the first question to generically describe those groups for which the data was the best. In the third question, we talk about the conditions in which patients may have with varying diagnosis that speak to the use of ECT and try to clarify that. The problem, I guess, is that we are somewhat artificially taking question by question in order to facilitate the discussion, and we may attempt, perhaps we need some reference to that because we don't close the door and clarify that in number 3. But we appreciate your remarks. Yes, sir.
Can I just make one small point about the...
You might want to remind us that you're Dr. Friedman, Dr. Friedman.
About the length of course of ECT and maintenance ECT. I agree there are no clear studies on the subject of maintenance ECT. There is one interesting study which I don't think has been mentioned by Barton and Smith, which addressed the question of when symptomatic recovery is achieved, is there any point in giving 1 or 2 more treatments, the so-called one for the pot treatment, the topping up type of method that was used very extensively in the UK some years ago. And they showed very clearly that there was no point in going on with any further treatments after symptomatic recovery had been achieved. There was no prophylactic effect of giving 1 or 2 more ECT at the end of the course. I think it was worth being up to 6-month follow-up of patients showing that you really had to stop as soon as symptoms were relieved and there was no advantage in extra treatments.
Thank you. Dr. Kuhn.
I think in light of some of the potential confusion about this 4-week effect and limited studies and how that might be misunderstood by people who don't do trials of acute treatments of all sorts, it might be good to put something in the statement to say that the evaluation of ECT as an acute treatment is very similar to the evaluation of other treatments of depression. That is, these studies are designed for brief, several-week trials. The majority of patients who complete these trials are discharged from the hospital, and that the question of recurrence of new episodes in an illness which is given to recurrences has yet to be addressed in relation to ECT, as it has been somewhat addressed in relation to other treatments. But simply to say that we don't know that it works beyond 4 weeks, I think is confusing to people who don't know the issues about how we evaluate treatments and the difference between treatment of an episode and long-term management. I think that little work on that part of the statement needs to be done.
We tried that, obviously we didn't do it as well as we might have done. Yes, please. One minute.
My name is Margaret Bader. I'm a Florida representative for the Community Clinical Psychiatry. I would like to address the top paragraph on page 4. Someone suggests that ECT reduces symptoms and severely depressed patients who previously have not responded to adequate trials of antidepressant medication. Has there ever been any consideration that there are patients who are allergic to your antidepressant medication, therefore increasing the symptoms, creating suicidal symptoms, and making the person worse, and therefore the recommendation is given to receive ECT. I would also like to add that a follow-up of the determination that you have defined does not apply to certain patients. It has taken me 15 years to restore what you took away from me in a very, very hard way. I was not followed up in any way after the hospital, in which I was released as cured, except to have relapses because I was on antidepressant medication, which kept sending me back to the same asylum, mental hospitals, and psychiatric wards. Thank you.
Yes, and then Mr. Hoffman after member of the press.
Yeah, this is Calvin Pierce from Clinical Psychiatry News. It's a little low.
Take it out of the hold.
Yeah, I'm interested too in the panel's statement about the long and the short-term efficacy of the treatment. We've seen a lot of statements in recent years about cardiovascular disease and cancer treatments where decisions have been made about treatment alternatives based on 5, 10, even 20-year recurrence rates, and sometimes very small differences. And I'm wondering how the panel could explain to the general public how it's able to make the recommendations it has on the basis of only 4-week duration follow-up studies.
Would someone like to try to answer the 4-week question that Evelyn asked about this? Not a 4-week follow-up. Come on, okay?
Well, is this on?
Yeah.
I think most depression is a recurring illness, and so that you treat each episode, and I think the efficacy then in the treatment of the acute episode, it's sort of like giving penicillin for a strep throat. One would not expect it to prevent strep throat 6 months hence.
I'm Edward Ogden. There are, of course, many ways in which I wish the consensus statement were written differently, but I'll confine my remarks in the interest of our limited time to one sentence on page 5. In the paragraph on schizophrenia, the second sentence as it's been written reads, ECT is generally more effective for those schizophrenic patients with a shorter duration of illness, more acute onset, and more intense affective symptoms. I think that this sentence, as it's been drafted, doesn't truly is incongruent with the evidence that was presented to the panel. And so I especially regret the endorsement of ECT for schizophrenia in this document. I will explain why, and I'll suggest a way in which it might be improved. The people diagnosed with schizophrenia historically have suffered the most frequent and worst abuses of the ECT. And I believe that the revival of ECT as a popular treatment for schizophrenia
is one of the most likely outcomes of this document. And I think the panelists would not want to put fear may occur. Now, the outcome research on depression, limited as it is a model of scientific rectitude compared to the outcome studies of ECT or schizophrenia. The reason for that is that modern scientific investigators, with very few, if any exceptions, have not been doing outcome studies on schizophrenia. I suspect that this advancement of outcome studies on schizophrenia has occurred because the modern investigators have concluded, as I have, that the older literature shows only the immediate organic brain syndrome, which of course suppresses the more bizarre and horrible symptoms of acute schizophrenia. And of course also the fact that the sudden onset, first episode of schizophrenia, has a good likelihood of improving with or without treatment. The evidence presented to you, the panel, at this conference was contained primarily in Dr. Small's slide, which was a slide that listed about half a dozen outcome studies on schizophrenia. I think if you would look into the references listed there, you would find, well, for one thing, you would find the Exner and Murillo study, which was one of those. That was an intensive ECT study in which the patients were shocked repeatedly and frequently into a state of vegetation, where they were acute and persistent organic brain syndrome. Those investigators concluded that that status was an improvement over what they had seen before. I don't think that's what the panel would regard as real evidence of improvement in schizophrenia. And I believe if you would look at the other references there, you would find that it's impossible to tell from the other references whether there is any improvement in the patients, any different from what Exner and Murillo found.
Could we, I think one of the panel would like to respond to that. I'd like to move on, if we could, to the next topic, because of the time.
I would like to suggest in conclusion, if I may, a way in which that sentence might be better written. If not entirely excised, which I think would be preferable. But if not entirely excised, I think it ought to be, the evidence is suggestive of effectiveness only for those schizophrenia patients with a short duration of illness, acute onset, and intense affective symptoms. That would cure the tendency of present wording to suggest that while it's most effective for some patients, it's also likely to be somewhat effective for others.
Thank you. Dr. Stutton?
Our intention clearly was not to have schizophrenia, have ECT be the first line treatment for schizophrenia. And we specifically state that in the first sentence. And we specifically state that it is not effective for chronic schizophrenia. And in terms of the regressive shock that you described before, we again state that that is contraindicated. We stated it this way in order to have an opportunity for schizophrenic persons who did not respond to medication or could not get medication because of medical contraindications, to give the practitioner some guidelines as to which schizophrenic persons might respond to ECT.
One electroshock treatment can equal the energy of 3 pistol shots to the head.
Dr. Rose accepted 2 pieces of literature for reference. I would hope and might make copies available for the panel. We're talking about having at least accurate information on the device and what we're using. And the one copy is the Thymatron, the brochure on a single sheet handout on the Thymatron pulse ECT device. And in there it shows the physical characteristics. The other, and pardon me for the emotional content of it, I also included a current Winchester ammunition catalog because it shows the energy with which the bullets have. Now that's emotional. I don't really want to bring that up. But running this machine at its maximum brings 201 joules of energy. That is 148 foot-pounds. if you're interested in actually understanding like the truth and energy, what they're talking about, 1 joule is 0.07376 foot-pounds. But what this means is this device, when operated at its maximum capacity, will lift a 1 pound weight 148.7 feet. The energy contained in that is equivalent to 3 25 caliber pistol slugs. Now that's almost instantaneous entering the brain. This takes a half a second. Now that is just pure factual data. To give that lifting of 1 pound energy equivalence in informed consent, how could you not do that? And if you're going to give a procedure, the total energy and the total time are the physical parameters that characterize the device. How could you not include that information? And if a doctor prescribes a drug, he has to record the prescription. Why isn't the total time and the total energy recorded? This has been an experimental hazardous device for years now. Why hasn't this information been gathered that we could be talking with concrete objective facts rather than subjective opinions of psychiatrists and patients?
One electroshock treatment can equal the energy of 3 pistol shots to the head.
All right, out with your gun. Out with your gun.
Okay, this won't hurt. It'll be over in just a moment.
Uh-huh. What's that?
Conductant.
Oh, that will do you. Right, Mr. Jackson.
Open your mouth.
What's that?
This will keep you from biting your tongue.
Well.
Now just bite down on it. That's right. Just bite down. Now bite down on it.
Good. Are you ready? Here we go.